Hi dear students, and my today's topic will be a pharmacological characteristic of oral anticoagulants. Hemorrhagic disease was described in cattle in 1924, which was due to feeding them on spoiled sweet clover hay. The disorder was found to be due to prothrombin deficiency, and the toxic principle was identified as bis-hydroxycoumarin in 1939. First clinical use of bis-hydroxycoumarin was made in 1941, and many congeners were added later. Warfarin was initially used as a rat poison. Demonstration of its safety led to clinical trial. It's now a commonly employed oral anticoagulant. Here you see mechanism of action of all anticoagulants. Firstly, you see normal factors of coagulation that take a role in coagulation. Here two ways: intrinsic pathway and extrinsic pathway. You see that in active factor convert to active factor, so 12 to 12A and then later. And for us interesting vitamin K antagonists, for example warfarin, it's block this inactive factors 8, 9, 10, 2 factor and factor 10A inhibitor. So it's inhibit this 10A factor prothrombinase. Warfarin. It's the most popular oral anticoagulant. It's metabolized relatively faster by renin oxidation carried out by CYP2C9. Warfarin is rapidly and completely absorbed from intestines and is 99% plasma protein bound. It crosses placenta and is secreted in milk. However, quantity of active form is generally insufficient to affect the sucking infant. So, dose of oral anticoagulant must be individualized by repeated measurement of prothrombin time. The aim is to achieve a therapeutic effect without increasing the chances of bleeding. When the patient take this oral anticoagulants, especially warfarin, he should control his INR, so international normalized ratio. And it can be a different range of this INR. So, in the case of prophylaxis of deep vein thrombosis and similar indications, INR should be 2.5. In the case of treatment of deep vein thrombosis, pulmonary embolism, transitory ischemic attack, hip surgery, so from 2 to 3. In the case of recurrent thromboembolism, arterial disease, prosthetic heart valves, so INR should be from 3 to 3.5. Adverse effect of oral anticoagulants mainly is bleeding, is a result of extension of the desired pharmacological action. The most important problem causing ecchymosis, epistaxis, hematuria, bleeding in the GIT. Intracranial or other internal hemorrhages may even be fatal. Bleeding is more likely if therapy is not properly monitored or when INR exceeds 4 or interacting drugs contraindications are present. So in the case of the bleeding, how we should treat? So first let's withhold the anticoagulant, then give fresh blood transfusion, then give vitamin K1, so vitaminadione. It's antagonist of warfarin, and it should be taken in 6-24 hours for the clotting factors to be resynthesized and released in blood after vitamin K administration. Cutaneous necrosis can be rare. The warfarin has a lot of interactions between drugs. It can enhance this effect or opposite, so decrease the effect. So factors that enhancing effect of oral anticoagulants: it's debility, malnutrition, malabsorption, prolonged antibiotic therapy. Then it's liver disease, chronic alcoholism, synthesis of clotting factors. Next it's hyperthyroidism and newborns. So have low levels of vitamin K and clotting factors. Factors that decrease in effect of oral anticoagulants. It's pregnancy, plasma level of clotting factors is higher, nephrotic syndrome, then genetic warfarin resistance. The affinity of warfarin to bind to the reductase enzyme, which generates the activate vitamin K, hydroquinone, is low. Then adverse effects will be except bleeding, thrombocytopenia, alopecia can be, elevation of serum transaminase, osteoporosis, and hypersensitivity like as urticaria, rigor, fever, and anaphylaxis. I want to mark that oral anticoagulants shouldn't be used during pregnancy. Warfarin given in early pregnancy increases birth defects, especially skeletal abnormalities. It can produce fetal warfarin syndrome, hypoplasia of nose, eye socket, hand, bones, and gross retardation. Given later in pregnancy, it can cause CNS defects, fetal hemorrhage, fetal death, and accentuates neonatal hyperprothrombinemia. Drug interaction, again, so some drugs can increase or decrease effects of warfarin. So enhanced anticoagulant action can be due to broad-spectrum antibiotics, for example, cephalosporin, ceftriaxone, cefoperazone. So antiplatelets, for example, aspirin. Then it's again synthetic antimicrobial drugs like sulfonamides, it's NSAIDs, endomethacin, phenytoil. It's antibiotic chloramphenicol, erythromycin, celecoxib, cimetidine, allopurinol, amiodarone, metronidazole. Then it's tolbutamide, phenytoin, liquid paraffin. Reduced anticoagulant action can be due to barbiturates, but not benzodiazepines. So it's due to carbamazepine, rifampicin antibiotic, rhizofulvin antifungal drug. They can induce the metabolism of oral anticoagulants. Oral contraceptives, the same, can increase blood levels of clotting factors. So, about some drugs from oral anticoagulant, it's rivaroxaban. Rivaroxaban is inhibit activated factor 10A. Its anticoagulant action develops rapidly within 3-4 hours of ingestion and lasts for 24 hours. It's largely metabolized but also excreted unchanged in urine. Another advantage is that it requires no laboratory monitoring of prothrombin time or activated thromboplastin, partial thromboplastin time, and it's recommended in fixed dose of 10 mg once daily, starting 6-10 hours after surgery for prophylaxis of venous thromboembolism. In comparative trials, its efficacy has been found similar to a regimen of low molecular heparin followed by warfarin. Rivaroxaban also been found equally effective as warfarin for preventing stroke in patients with atrial fibrillation. Side effects reported are bleeding, nausea, hypertension, tachycardia, and edema. Dabigatran, it's the same oral anticoagulants. It's a prodrug which after oral administration is hydrolyzed to dabigatran, a direct thrombin inhibitor which reversibly blocks the catalytic site of thrombin and produces a rapid anticoagulant action. Though oral bioavailability is low, the anticoagulant effect is consistent. And no laboratory monitoring is required, like and rivaroxaban. No, the dose can be started from 110 milligram and before 150 milligram twice daily. And indications of oral anticoagulants: it's deep vein thrombosis and pulmonary embolism, it's myocardial function in unstable angina, it's a rheumatic heart disease, atrial fibrillation, vascular surgery, prosthetic heart valves, retinal vessel thrombosis, extracorporeal circulation hemodialysis, defibrillation syndrome, cerebrovascular disease. So thank you. The last table, it's about comparing of oral anticoagulants. So you can see that warfarin bind with protein on 99%. It means that it has a lot of interactions between drug. So time to peak concentration 4 hours. Dabigatran, comparing with warfarin, less protein binding has, so 35%. Time to peak concentration can be from 1 to 6 hours. And rivaroxaban, the same, has high protein binding, before 95%. Time to peak concentration to 4 hours. So thank you for your attention.